I, of course, changed my talk, because that's what I always do, and the title. But it's all pretty much the same. Most of the slides you will have, some were removed and others added in their place, so just bear with me with your syllabus. So what I'm going to do is spend the first part of this making my argument about the diabetes epidemic, the current healthcare standards and why, or healthcare system and why it's ineffective, looking at different aspects, including patients, providers, and healthcare systems. And then finally, the second part will be looking at our ECHO program. So, can we prevent or delay diabetes? Yes, we can. A large landmark study that's now fairly almost 10 years old demonstrated that if you give people with pre-diabetes intensive lifestyle intervention, and I think there is a speaker talking about this a little bit later, to reduce their weight by 7% and increase their activity by 150 minutes a week, you can prevent diabetes. That intervention group is shown in the light blue line compared to placebo or a dummy pill. If you give them a diabetes medication, even without having diabetes, you can also prevent it from occurring or delay it. But we're not. So this is a graph that looks at the persons with diabetes between 1958 and 2004. In 1958, 2 million people had diabetes in the US. In 2004, it went up to 16 million. I couldn't figure out how to adjust the graphics. In 2008, 24 million people have been diagnosed with diabetes. The anticipated number is that 1.5 to 2 million people, new people each year, will be diagnosed. Why did this happen? Well, there's more people. There are more stringent criteria for diagnosing diabetes, and we're doing a better job of screening. But that certainly is not enough to explain the several-fold increase. But several things can. So the TV. In the 50s and 60s, most people had a television and an automobile. So instead of doing other things, now you could you could drive around in your car, drive home, and sit in front of the television. Huge spike in diabetes, because people were more sedentary and they started gaining weight. In the 70s, almost all communities, even rural communities, had access to a fast food restaurant. So now you could drive your car to the fast food restaurant. You don't even have to get out. Go through the drive-thru, pick up your stuff, go home, sit in front of the TV. Another spike in diabetes. Then in the 80s, we stopped exercising. We pulled physical education out of the schools. We no longer deemed it safe to go out and play. Now in order to play, you have to go on a play date. Who's been on a play date? Not that kind. My kids go on play dates, and well, they don't. But the way it works is a mom calls up another mom and says, "Can my kid play with your kid?" And then that mom drives that kid over, and they play video games for 2 hours, and then drive home. And then finally, of course, we've been computerized. So now you can actually order that fast food stuff, and they'll deliver it. You can talk to people, you can buy stuff, you can sell stuff, you can watch movies, you can listen to music, you can date. I'm even told that you can take the next step after dating, but I don't know how, so I'm going to leave that up to the health information technology people. So really, all you need to do is go wash your hands afterwards. But now it gets better. Now we have these water-free hand washing things. You just put that next to the computer. You never have to leave. And finally, we've been supersized. I'm trying to make you laugh because it's going to get really depressing. So, we can't prevent diabetes, but can we prevent the complications? It turns out we can. I'm not going to go over this one in detail, but this was a study treating patients with diabetes with high or low-dose statins, cholesterol-lowering medications, and they demonstrated that you get significant reductions in cardiovascular outcomes, particularly if you use the higher dose drug compared to the lower dose. But we know that statins work to prevent cardiovascular disease in people with diabetes and in people without diabetes. We also know that if we actually treat diabetes, we can delay or prevent complications. This is another very old study done in the UK looking at intensive glucose control versus regular control. And in this point in time, intensive wasn't what we even think about it today. But the people in the intensive group had significant reductions in microvascular disease, kidney disease, eye disease, and a non-significant decrease in large vessel disease. 10 years later, a study showed that all those people who were in that initial intensive group had a benefit for all cardiovascular outcomes. Unfortunately, as we're not preventing diabetes, we're not preventing the complications. And this is an unfortunate slide looking at that. Two different time frames from the NHANES study, 1988 to 1994 versus 1999 and 2000, looking at achieving A1C targets less than 7, so that is your measure of glycemic control. We actually got worse with the second cohort. We went from 45 to about 38. Only 38% of people with type 2 diabetes in this cohort had achieved their A1C target. Blood pressure numbers are worse, although it did get better in the second cohort, but well below 40% of people with hypertension have their hypertension controlled. Statins were a little bit better, but still well below 50%. And we know that none of these diseases lives in a silo. They all contribute to one another. And so people who had control of all three were fewer than 10%. As a result, every day there's at least 4,000 new cases of diabetes diagnosed. Almost 1,000 people die a day. Almost 230 people lose part of a limb. 120 people start dialysis. And 55 people lose their vision every day. It gets worse. In kids, children who were born in the year 2000, the estimated lifetime risk of developing diabetes is about 33% if you're a 10-year-old boy now, and about 38% if you're a 10-year-old girl. If you are a minority or a person of color, the numbers are even worse and start to exceed 40% in Hispanic boys, almost 50% in Hispanic girls, and in African Americans. Oh, I'm sorry, that was wrong. African Americans and then Hispanics have higher rates. Native Americans are not included on here, but they're very similar to Hispanic rates, if not higher. So almost 55% of Native American born girls, they're 10 now, will develop diabetes. There's more bad news. So a bunch of them have it now. Anybody know any kids under 10 who have diabetes? Anybody see them in your practice? So several hands. This was unheard of 10 years ago. Many more will get it in their teenage years. And many more, and the rest will probably get it in their 20s and 30s. And the complications of diabetes tend to lag behind it by about 10 years, which means that a significant percent of children who were born in the year 2000 will have diabetes complications in their 30s, 40s, and 50s. Now, this is the really important part. What's going to happen is they're going to be pulled out of the workforce because of those complications. They're not going to then contribute to the tax base, to Social Security, to Medicare. In fact, they're going to consume those resources. So, this is likely to result in a healthcare disaster. Not only will we not be able to retire, most importantly, because there's not going to be any money because they're not contributing, but we will have to be taking care of this younger population. So I showed you up to 2008. Predictions suggest that by 2033, 40 million people will have diabetes. The cost is expected to triple in that time frame, from about $100 billion now to about $300 billion in 2032. Hopefully, many of the initiatives that were discussed earlier will help prevent that from happening. So, to summarize the problem, we can prevent diabetes, but we're not. We can prevent complications, but we're not. And we're really witnessing the tip of the iceberg. Unlike previous epidemics, such as flu, plague, etc., this one will kill people slowly but very expensively, and the financial toll will be astronomical. So why? So now that's the problem. Why are we here? Why can't we do a better job? So there are multiple restraints or barriers, from the healthcare system to providers, including dissemination of new information, changing in provider practice behavior, clinical inertia, communication, retention, etc., the list goes on. There are many patient barriers, including comprehension, adherence, cost, fear, and these barriers are compounded, as you know, in rural, minority, and other underserved populations. Just want to step back for a moment in time. At the turn of the 20th century, significant advances over the next 50 years occurred, including immunization programs, antibiotics, clean water, prenatal care. All of these initiatives led to increases in longevity. And interestingly, most of these initiatives were actually carried out by lay persons, community health workers, etc. These are not high-techy things. They're not expensive, but they resulted in a significant increase in longevity. So the mean age the mean life expectancy for a man in 1900 was 47, and for a woman was almost 50. That increased by about 50% to men 75, women to 77. What's going to happen in 2100? The way the trend is, the lifespan will be shorter. First time in history that it's anticipated that children of this generation will live a shorter lifespan than their parents. First time in history. And likely their parents will outlive them and will be providing their chronic care near the ends of their life because of diabetes. So in addition to having longevity, we develop chronic progressive diseases, such as asthma, COPD, cancer, obesity, diabetes, heart failure, chronic infections, HIV and HCV, and all of these tend to have a behavioral component or a lifestyle aspect or environmental component. They all mandate increased utilization of healthcare resources, and it's very expensive to treat these chronic diseases. The healthcare system was never designed to deliver chronic, complex care. The focus has always been on the acute problem. There's no time, historically, for comprehensive care. Emphasis has been on benchmarks and with questionable clinical relevance. Reimbursement for prevention and counseling has been a barrier. Lack of specialists and providers in rural areas is a problem. Little attention is paid to the behavioral or psychosocial aspects of health. And there's been accelerating costs, accelerating co-pays, under or uninsured. The famous 15-minute office visit. A study was done that demonstrated that 50% or more of patients didn't know what happened. They walked out and they don't know what happened in that 15 minutes. It's not actually even 15 minutes that you get. That's the total time for your health care. Over 42% of providers feel rushed and like they're providing inadequate care. It's not really what you want your healthcare physician or provider to be feeling. It takes 7.4 hours to manage a primary care panel of 2,500 patients. If they happen to have a chronic disease, you've got to add about 10.6 more hours. You can do the math. Unless there's a cot in the clinic, care is going to be inadequate. Everybody hates it. I've never met anybody who likes it except for the people who earn money from it. And you just cannot do diabetes in 15 minutes or less. You just can't. How about how providers or clinicians get new information? So we go to medical school, we go to PA school or dental school, and we learn everything, and we do it on patients, and then we go out and practice. 10 years goes by, new information comes out. How do we get it? Or what do we do with it? So a large study that was largely federally funded, looking at hypertension and 4 different drugs, only one of which was a generic at the time, the diuretic. This was a $130 million study. A lot of the money came from the pharmaceutical industry, but a significant amount came from the federal government. Looked at 42,000 people, and they found that the diuretic, the one generic drug, was actually better, as good or better than any of the other agents. It contributed to national guidelines on blood pressure regulation, etc. And so did prescribing behavior change? 1 year after the study was published, diuretic use increased from 30% to 40%. So a 10% increase in the use of what's considered a better, if anything, drug, a cheaper drug, and $130 million later. So these large randomized clinical trials that we use to promote evidence-based medicine really do not get out to the people who are in charge of people's health care. What about how else we learn? CME, Continuing Medication Education Credit. This has typically been focused on quantity of hours, not quality of hours. Retention rates from the information being portrayed are limited, just like you're not going to retain anything I'm saying here. And then historically there's been commercial bias, so it's been sponsored by pharmaceutical industry and they kind of sway you to their product. Little emphasis is meant on developing and implementing quality improvement programs, improving performance and patient care, and promoting mechanisms of lifelong learning as well as interdisciplinary education. Clinical inertia. This is defined as an overestimation of the care provided using soft reasons not to intensify therapy. Classic example that the residents do is, the patient comes in and their A1C is 12, but that was done 3 months ago, so let's just recheck it, and then we'll address it. Well, the addressing comes 3 months later when, again, they say the same thing, so things never move forward. Lack of education, training, and practice management aimed at achieving treatment targets, and clinical inertia tends to occur in providers caring for people with chronic progressive diseases, because it's hard. And usually they have a behavioral component, so it's easy to point your finger at somebody else. Examples include initiation of insulin or advancement of statins. The current model of healthcare is there's a provider. They see 20 to 25 patients a day for 15 minutes or less, and they direct care to the patient. They get some ongoing training now and then that's driven to them, not by them. And the family and the community are out there in the cold. So we know we've got rising rates of obesity, diabetes, and its comorbidities. The healthcare systems are really not designed to deal with chronic, common, complex diseases, including diabetes. Providers do not receive the tools they need to actually do this, and patients do not receive the resources either. So, here's a solution. Extension for Community Health Outcomes, or Project ECHO, was founded by Dr. Sanjeev Arora, who's a hepatologist, and I'll get to his story in a second. But the way this works is we use technology to connect rural providers and practicing in rural and underserved areas with a UNM Health Sciences Center multidisciplinary team. Providers actually present patients that they are seeing in those communities whom they would otherwise consider referring up to a subspecialist. There's didactic learning, direct patient case-based learning, and co-management. It increases collegiality and collaboration because multiple participants are on at the same time. I don't have the data today, but some of our surveys have demonstrated that that makes them feel less isolated and potentially more likely to stay in those rural communities because they develop new skill sets, they have new colleagues, they don't feel isolated and alone. We actually give CME credits using this interaction patient case-based program. It was started for hepatitis C. In New Mexico, there was one hepatitis C provider in the early 2000s, and that was Dr. Sanjeev Arora. And there are 32,000 people infected with hepatitis C, which for New Mexico there's a higher incidence per capita. We only have about 2 million people in the state, so this was a big number. So in order to get treated, you had to go see Dr. Aurora in Albuquerque. There's a potential for significant morbidity and mortality and cost without treatment, and there is potentially curable treatments. But in order to see Dr. Aurora, his wait list started to become 4 to 7 years, which is enough time to actually die from hepatitis C. So he was not sleeping at night anymore because he was always seeing patients, and it was affecting his family life, and he realized he needed to do something. And he started to analyze the problem. So there weren't enough specialists doing hepatitis C in urban or rural areas, and most of the hepatitis C was in rural areas. Primary care providers were not even diagnosing hepatitis C at this time, much less treating it, because they didn't know how to or didn't have the skills, and the drugs are new and kind of toxic. Lack of other services in rural areas. Again, to get treatment, you had to travel to Albuquerque, and this could be a 5-hour drive in some cases. And you have to go in regularly, so it's not once every 6 months, it's once a week or once every month. And the treatment's fairly expensive. So what he decided to do was train rural providers, not local, rural providers, to actually do the screening for high-risk patients and initiate treatment based on treatment protocols. It started with HCV. It has since moved on, and I'll show you that later. So what it does, the way it works, is rural providers, even if they're the only nurse practitioner in that area, can connect on a weekly basis, present their patients, listen to other rural providers from this place and that place presenting their patients, and they discuss co-management together. In the case of hepatitis C, there's many people on the multidisciplinary team, which I will show you. Patients get then specialty level care without having to leave their communities. So the way it works, here's your primary care team out there. And then we've got multiple different echo programs. Each session usually meets once per week. There's always a didactic component that's driven by provider request, and then cases are reviewed. Free CME, patient co-management, it's interdisciplinary, and there's 24/7 hour support. I don't like that term. It's too obligating. I was going to say something. In hepatitis C, they actually will do about 20 cases in the period of 2 hours, just much more than you can do in a clinic visit. In diabetes, we typically have about 4 to 7 because we spend a lot more time talking about behavior. So here's what it looks at from the UNM end. There's Dr. Aurora. There's also an infectious disease doctor, a psychiatrist, a pharmacologist, several nurses, an IT person, and then on the screen are the rural sites. This is a rural site, Espanola, New Mexico. It's the heroin capital of the world, highest incidence of heroin abuse. And that is a physician assistant and a community health worker. They are presenting patients to that team back in Albuquerque, and then together they will come up with a management plan. And you can see there's multiple other participants on the screen as well. Many people come in by phone because they don't have broadband access, or good enough broadband. So the model actually works. There's been more than 700 sessions held, more than 7,000 presentations, over 700 people have been treated, CME hours have been given, and training at the rural sites. Before this project started, the federal prison system in New Mexico, well, I don't know if it's everywhere, but there was nobody was being treated for hepatitis C. And hepatitis C is rampant in prisons. approximately 50% of people have it. So with this program, we're actually able to initiate a hepatitis C program in the prisons. So it was successful. It's won numerous international and national awards for its innovation. It's largely funded by grants, so it's soft money, but the legislature does contribute, the state legislature. Providers actually really find it appealing. They get new knowledge, they have a new skill set, they feel better about what they're doing, they like collaborating, and they don't feel as isolated. It's been expanded to many other disease states, including rheumatology, HIV, asthma, substance abuse addiction. We have a Suboxone training program, behavioral health, et cetera, et cetera. Here's a map of New Mexico. You can see the population density. The redder you get, the more populous you are. You can see there's not very much red. There's very little yellow, and in fact there's mostly green, which means we're a very rural state. We have all but one of our counties are considered medically underserved and healthcare professional shortage areas. We have several counties where there's not even one certified diabetes educator. And here's a map of ECHO programs. So there's different colored programs in different areas almost throughout the state, and it largely reflects the rural population as well. So what about diabetes and the ECHO model? Yeah. So Dr. Aurora sent me, after the success of his program, he said, why don't you do this for diabetes? Because there's 300,000 people in New Mexico who have diabetes. So we can really have a big impact. So he sent me all over the state to go find champion clinicians, administrators, etc., to really buy into the effort. So you got to buy in because you have to spend an hour a week on this teleconference instead of seeing patients. So I went out everywhere, Hobbs, all those places. Where are they? Those dark places all over. Scary. And this is what, and I came back with, I came back with nothing. Said, well, how many did you get? I'm like, I didn't get anyone. Nobody wanted to do it. It's like, and he thought I was nuts. I am nuts, but he thought I was. So he said, well, why? I'm like, they're just not interested. And this is what I heard out there from rural clinicians. Well, it's just diabetes. They could die from HCV. Well, we're already seeing them. We really want to focus on HIV and rheumatology, diseases we can have an impact. The health educators aren't doing their job. I'm doing everything. The patients won't do what I tell them. I've done all that I can. It's not on people's radar. It's amazing. I was amazed. So barriers to using it in diabetes. Providers' experience with treating patients who are either non-adherent or don't have the resources to be adherent is a problem. And then you start to transfer that failure to the next patient, et cetera, et cetera. And so you lose interest. Clinical inertia, as I mentioned, is abundant. And there's time constraints to actually treating diabetes. So I got to thinking, well, whose fault is it? It's genetic, it's the patient's fault, it's the family's fault, it's the doctor's fault, it's the healthcare system's fault, it's the government's fault, it's the food industry's fault, it's the TV's fault, it's the dog's fault. All of these are true except the dog. For if we had the dog and we loved the dog and walked with the dog 2 miles a day, we wouldn't have this problem. Now we have a pet obesity epidemic because our pets sit there on the couch next to us. They are not doing the internet thing yet, though. So diabetes is common, it's complex, it's chronic, it's multifactorial, it's not going away. It's not sexy, like hepatitis C, where the drugs are dangerous and exciting. It's exhausting. It requires a complex, chronic, multifactorial, multifaceted treatment, and it's never really received the respect it deserves. Gates Foundation. Totally interested in infectious diseases, not interested in this. It's great what they do, and it does take a village. So who needs to be on the team? the patient and the family, the community, the provider, the nurse, the MA, the CDE, if you have one, the dentist, the optometrist, and of course the doc. And finally, what we've came to realize are community health workers need to be on this team, particularly in rural and underserved areas. I already mentioned we have many counties that don't even have a diabetes educator. Some practices are just solely one nurse practitioner and an MA. So there's a huge need to expand the healthcare workforce, not just for providers, but for other members of the team. So community health workers, I have a feeling many of you are aware of them, what they do. They have been participating in healthcare throughout the world for centuries. They go by many names: paraprofessionals, community health representatives in Native American communities, Chinese barefoot doctors, street medics, Katrina angels, promotoras, health advocates. Chinese barefoot doctors is an interesting example. So when Mao Zedong came into office, he wanted to socialize all of medicine, so he sent out providers to rural China. Well, they fled China altogether because they didn't want to do that. And so the women in the villages started to take up the slack. So they would go around to people in the village and offer immunizations, et cetera, et cetera. They were poor, they didn't get paid to do this, and they often didn't have shoes. Barefoot doctors. Community health workers bridge the gap between the community constituents and the healthcare system, breaking down educational, cultural, language, and other barriers. The example I like to use is community health representatives in Native communities. Usually what happens is an IHS doctor comes in for loan repayment for 3 years and thinks that they're really pouring out their soul to help these poorer people, yet doesn't understand the cultural barriers and cultural differences that are present, or cultural attitudes in those communities. And so after 3 years, they're done. A new one comes in. There's never a sense of trust being developed by the Native American communities. But community health representatives who are in there, they understand the language, they understand the resources available, they understand the cultural opportunities, can really help bridge that gap. They have been demonstrated to be successful in promoting prenatal care, child health, immunizations, clean water, HIV and AIDS in Africa, and in fact, paraprofessionals probably do most of the HIV intervention in Africa. These are non-degreed people, usually. Specialty level community health workers is an emerging field, and the multifactorial aspects of diabetes makes using community health workers as members of the healthcare team an attractive endeavor. Using this model, we now can have a three-way conversation. The provider works with the patient, the community health worker facilitates the interaction between the two, interprets what happened in that 15 minutes, and reinforces behavior change. The family and community are thus then involved, and using the ECHO model, case-based or quality improvement learning occurs. So where's the data? These are not my data, but a community health worker intervention shown in orange versus usual care shown in blue led to significant increases in cardiovascular exercise, increasing exercise habits over time, healthy eating, and healthy eating habits. Significant reduction in hemoglobin A1C if you participated in the community health worker program, 8.4 to 7.4. That's as good as you're going to get with any drug, except for maybe insulin. Significant percentage of people are achieving their goal A1C. Significant improvements in cholesterol if you participated in the program. Another different program using a community health worker as the sole diabetes educator. So they don't have a certification. And then they looked at participation pre and post. Full participation is shown in the darker box. Partial participation in the hatched box. Significant reduction in A1C over the first 6 months if you fully participated. Even if you partially participated, significant reductions in A1C after 1 year. 1.5 or 15%, which is, again, better than almost any drug and cheaper. Another example, using a community-based clinic, community health worker model versus enhanced primary care, which I don't even know what that means. Significant improvement in blood pressure, LDL, and smoking cessation. So there are limitations to the community health worker model. First of all, training. It costs money to train. They have to pay tuition, etc., to get to a training program. They have to usually travel, so if you're in rural, underserved areas, that is a barrier. Trainings are of limited duration and capacity, and of limited scope, and not sustainable. So what we did was we took the ECHO model and started a training program for community health workers. We actually bring them to Albuquerque for a 3-day intensive on-site training where we focus on clinical skills, communication, etc. They have video modules which they can watch asynchronously, and then they participate once a week from their communities in the ECHO training session, where again we do didactics, they present clients or cases that they're seeing, we do Q&A and a lot of resource sharing. They get a certification of completion and proficiency in their skills. It's not a statewide certification. The state of New Mexico has been trying to move in this direction for the past 20 years. And the last I heard was the director of it said, well, now it's time to step back and take a look at where we've been. And so we couldn't wait for the state to come through, so we decided to go ahead. Some states do have certification programs, and some of you are from those states. And some of those work, and some of those don't work. And then after they're done, then they can participate in the regular ECHO diabetes clinic. So our first training, we had 23 participants, and what we demonstrated was there were significant improvements in their diabetes knowledge, in their confidence in both clinical and non-clinical skills, and in their attitudes towards, one, treating people with diabetes, also towards interacting with the healthcare system and the healthcare providers. So here's a list of our current diabetes ECHO programs that I'm in charge of. We have one diabetes cardiovascular risk reduction program, and that's for clinicians or providers of all types on a weekly basis. It's the standard ECHO. We have the community health worker training program, a program called Project Blue, which I'll tell you about in a minute, and a pediatric overweight program. We also have a high-risk pregnancy, which is largely diabetes. I'm not involved in that one. So our regular clinic meets once a week, usually have 10 to 20 participants, all sorts of levels of training. And I'm just going to mention resource sharing is a huge part of this clinic. So provider A in Hobbs, New Mexico says, I cannot find test strips for my patient. And provider B up in Raton says, you know, I found this great resource where you can get them for $10 for 60 strips. So all of a sudden you're sharing resources and not trying to reinvent a wheel that can't even be invented. Oh, and the CME credit is free, which for rural clinicians is pretty big because, one, it's hard to get CME credit. So if you participated once a week in one of these programs, you get 52 hours over a course of a year. Diabetes Blue, Basic Learning, Understanding, and Education, was an initiative that was started based on an ECHO participant's request. And multiple of them responded as well. Well, we don't have time to actually do that. You have diabetes day visit. So when they come in and we tell them they have diabetes and they have to do this and this and this, they first of all don't understand anything that happened because, one, it's 15 minutes. And two, when you get a diagnosis of diabetes, it's almost like getting a diagnosis of cancer. It freaks you out. So you stop listening. So then they have to come back, and by then the opportunity is lost. So we decided to start an anonymous phone line for peer-to-peer education for newly diagnosed patients with diabetes. So there was a specific time of the week they could call, talk to a peer educator, and get all of their questions, or some of their questions, answered. They weren't doing medical management. It was more about question and answer. It's convenient. It offloads from providers so that they can have time to do stuff they're actually good at. And it's good for patients. It has not taken off as successfully as we had hoped. But we'll see. We could use a grant. Just a couple minutes on the Childhood Overweight and Obesity program. We call this COMTC. This was developed by Dr. Jane McGrath, a pediatrician. Unlike adult diabetes, pediatric providers are desperately seeking information and assistance in managing obesity, metabolic syndrome, and diabetes in kids. This wasn't an issue when most of them trained 10, 20 years ago. Nobody who was under the age of 20 had diabetes, well, hardly anybody. So they didn't get trained on the medications either. Family complacency and certainly the exacerbating factors all contribute. So particularly rural providers are really facing a dilemma. So we have a dedicated clinic doing this just for pediatric obesity. And it follows the same program. Who we have at our table are myself, an endocrinologist, a cardiologist, a renal doctor, a psychiatrist, a nutritionist, a motivational interviewing specialist, and social work. And we really focus on the holistic approach to care and really trying to get providers, one, to recognize it and how to address it. Dr. Jane McGrath, who I think is a great innovator, found a mechanism to actually get even increased provider buy-in. She got approval from the pediatric board to allow this to be one of the mechanisms that you could get your maintenance of certification, which you have to get every several years in order to keep your licensure. So by participating in the program, you could fulfill one of those requirements, which is big. Let's see. Just a couple other ECHO initiatives. We have I'm not going to highlight all of them, a prison peer HCV training. So what we do is we take prisoners who were treated for HCV and they become the coach or the peer educator for new prisoners about to embark on HCV treatment, because there's lots of toxicity and side effects and blah, blah, blah. We've got other community health worker programs and many other initiatives. So, two concluding slides. Diabetes and its complications are not going away, and in fact are increasing, particularly in our children. The current healthcare system is not equipped to deal with this epidemic. Mobilizing community health workers as members of the workforce and the team may help meet some of these unmet needs. And we need to get out of the box. ECHO has demonstrated quality and safety in improving patient care, rapid learning, reduction and variation of care provided, access to rural and underserved areas, which reduces disparity. The training programs are force multipliers for healthcare. Providers feel, or clinicians feel, happier in their jobs. It does support the medical home model. It is cost effective and avoids the need for excessive cost of testing and travel, et cetera, et cetera. So I didn't include this page, but here are some resources, and I believe I have time for a question or two. Yes. I think there's a mic, unless you can talk loudly. It's okay for me.
Okay. Hi, my name is Minak and I'm a PA from Open Door Health Center in Mankato, Minnesota. And if you come to me when you go around to New Mexico and ask, I would love to participate. This seems like a great program. How can we extend to other places? What step we can start to get this program going on in other states?
Okay, thank you for that compliment. So you can contact me or us, and we can, there's several options. We actually now have, it's kind of foreign concept to me, replication projects, and we have replication days where visitors come. And at ECHO we said, the visitors are coming tomorrow. Like, are they from outer space? And then they're people who are interested in learning about the program. So instead of us having to go out to individual places all over, we bring people to our place. And if you're from Minnesota, you want to go there now because it's 75 and sunny. And so that's one option. But I think just contacting us. And you can get onto the website and actually get the 1-800 telephone number and listen in on a session if you want. And you can pick from any of the variety of sessions. So I think just contact me or one of my people and we'll talk.
Great, thank you.
Thank you.
I have a very basic question. We're looking at enhanced primary care and also the community health worker module. We don't have either one right now. How many, on average, patients could a community health worker assist?
It depends. You know, they can, what we try to do is we see the patient and do the doctor thingy, and then send them to the community health worker who reinforces what happened in the visit and then spends extra time doing education. And that can range, you know, from 30 minutes to an hour. It's longer for a new patient. They can also do group type visits and provide the education aspect of that. And so, you know, anywhere between 10 and 20 a day, if needed. They have to go out and do outreach. They have to do phone calls in the interim. And so I think, I'm just trying to remember what the capacity is. I think most have about anywhere between 200 and 300 clients at any time.
And most of their activities are within the clinic then? Outreach, or most of their activities are outside of the clinic?
The ones that we're working with now are usually in the clinic, but they go out. They do outreach. Many programs, they're not in the clinic, and so they're just doing programs, etc.
You're kind of doing a blended enhanced model.
Yeah. I don't know.
You're doing it all.
Yeah. Okay. Other questions? Okay. Well, thank you for your time.